Look, the striking thing is not that the NHS has a climate plan, it's that 5 years in, the money and managerial energy poured into it have not shifted the numbers that matters most. And while numbers the public cares about have moved in the wrong direction, we're stuck at roughly 27.3 million tonnes of carbon dioxide emissions that the NHS can influence in 2024 to 2025, which is basically where we were in 2019 to 20. Yet at the same time, the waiting list has crept up again to 7.41 million cases, and A&E is bracing for a bad winter. That is the dissonance people hear. So the NHS has one foundational purpose, that is to get sick people seen, diagnosed and treated in a reasonable time. At the moment it's not doing that. We have 6.2 million or so individual patients in the queue, cancer standards missed for a decade, ministers still searching for capacity. Every pound that is not visibly improving access looks suspect. Yet alongside that, the NHS now carries a statutory duty to consider climate effects, plus a self-adopted ambition to be the first net zero health system by 2040-2045, and an overinflated bureaucracy with CEOs paid far too much for what they deliver and surgeons and doctors and nurses paid far too little. That has produced a large ecosystem of green plans, supplier questionnaires, fleet targets and blue plates. The problem is not that the goals are wicked, it is that the outputs are soft while the clinical pressures are hard. According to reporting, at least £1.4 billion, an astronomical amount, has gone on net zero schemes that have not lowered the overall footprint. Some elements may have worked. Direct emissions are down from 5.5 to 4.7, mainly by cutting high warming anaesthetic gases and moving to lower impact inhalers. That is genuine and it should continue, but the big number, the NHS Carbon Footprint Plus, has stayed flat because the system buys more, travels the same and treats more people. So the headline to the taxpayer is spend big, no visible total fall. Now look at where the money is actually going. Electric ambulances and fleet conversion. Up to 80 fully electric ambulances are about £180,000 each, plus millions on charging points for travel emissions that still sit at 0.7. In other words, the spend is real, but the emission share is small and hasn't shifted. Worse, trusts admit that they're nervous about range and charging time, so the vehicles are being used as extras, not replacements. That is a classic example of capital getting ahead of operational reality. The net zero managers and the green plans, all 229 trusts and 42 ICBs have told to have senior people on net zero to file annual progress to make suppliers jump through 135-point questionnaires that will get tougher in 2027. That's an administrative architecture. It's not a cancer scanner or an additional theatre list. Blue plates and behaviour nudges are another thing. You know, the trials on cornflour blue crockery probably did reduce waste on those wards, and food waste is not trivial, but when you roll that up across England, the cost of replacing plates starts to look like symbolism at scale. Critics are not wrong to call that tokenistic. And the solar stuff, Ed Miliband's £250 million for panels on 260 NHS sites may well cut bills in time. Lower energy bills are good, but this sits in the capital column while people are waiting 62 days plus for cancer. The optics are terrible. At the same moment, England has not got back to the pre-pandemic performance level that the public remembers. We are still at 7.4 million on the list, and trusts are being paid to clean the list because it is so swollen. Radiotherapy UK has already warned that delays of even 4 weeks raise the risk of death for cancer patients. So when people read that the NHS has spent 7 figures on electric vehicles that then sit on charge for 4 hours, they ask the only reasonable question: why was that not spent on diagnostics, theatre or staff retention? The former Health Secretary, Steve Barclay, put it bluntly: first call on money should be patient-facing care, especially tech that speeds diagnosis and shortens surgery time. That is orthodox health economics. You relieve bottlenecks, you shift care closer to home, you increase day cases, you reduce follow-up, you improve survival. That's also lower carbon because nothing cuts emissions like avoiding an admission in the first place. Which means the greenest pound in the NHS is often the clinical pound, not the plate pound. If we strip away the outrage, there is a simple reason the total hasn't fallen. The NHS is a consumption-heavy service. It buys from a huge global supply chain, it relies on staff and patient travel, and it is treating more. The Greener NHS report itself says they have improved the methodology, which makes the number look stickier, and that future gains will be harder. In other words, the easy wins have already been banked. The rest requires big changes on how care is delivered. And the fact that care isn't being delivered on time at the moment doesn't help. The King's Fund and others have been saying for a while that the real carbon gains come from three things: preventing illness, managing long-term conditions outside hospitals, cutting wasteful or low-value procedures. I would say there's a fourth, and that is cutting a lot of the bureaucracy and the bureaucrats who are taking far too much money for what they deliver. But all three of them, of the things, or all four of these, are what Wes Streeting has been trying to do in his 10-year plan. Well, perhaps not so much the bureaucracy. That is where net zero and waiting list reduction can line up. At the moment, policy is not lining them up clearly enough. So, you have Sir Keir Starmer flying 9,000 miles to a COP conference and an NHS that cannot get below 7.4 million. You have Ed Miliband putting panels on roofs while junior doctors are planning another walkout. You have trusts being inspected on whether they have a green plan, while cancer targets have not been met since 2015. That is why this is insane. It's not climate action that's insane, it's choosing visible climate performance ahead of visible patient benefit. A more defensible order of battle would be to fund the things that cut weights and cut emissions altogether: virtual wards, one-stop clinics, day case surgery, GIRFT-style standardization. Those have evidence and they stop people being in energy-hungry hospitals. Retrofit estates where the payback is short and measurable. Old boilers, leaky windows, bad lighting. That's boring, but it saves money and carbon. Defer experimental or low-yield items until the backlog is moving down steadily. That's where blue plates, high-cost EVs in rural trusts and gold-plated reporting frameworks should sit. Keep the hard-to-reach 2024 and 2040 and 2045 targets, but stop pretending they can be delivered at no cost to service. If NHS England began reporting every green pound alongside patient capacity at unlocked, the argument would change overnight. Right now the reports are separate, which makes it easy for critics to say this is ideology dressed as healthcare. Climate and health are linked. Heat waves kill frail patients. Air pollution worsens COPD and asthma. So it is reasonable that the NHS cuts its own emissions. What is not reasonable is to look at a list of 7.41 million and tell people that the priority is cornflour crockery and a fleet that cannot yet do the miles. Until the green programme is tied tightly to delivery, to cancer timelines, to community care, to heart disease, people will go on calling it insane, and I would struggle to say that they are wrong.